And I want to get us in the mindset to listen to an awesome lady. Gail Stern, I met at the American Psychiatric Nurses Association. She is the president-elect for the APNA, and I voted for her, so I'm hoping she notes that somewhere.
That's why I came.
That's why you came. She is the, let me just digress a second. She's a board-certified psych mental health clinical nurse specialist. She's the first nurse to have ever held the position of administrator in the Department of Psychiatry at Lehigh Valley Health Network in Pennsylvania. She's a dedicated advocate of integrating physical and mental health care. And Gail, as I mentioned, is the next president-elect of the APNA. And I want you to welcome my fellow Pennsylvanian, Gail Stern.
Thanks for voting for me. I had run a couple times before and I'd lost, so I was trying to play that card, sympathy card, but I did finally get elected. So anyway, let me just tell you a little bit about my history. So I've been a psychiatric nurse for 41 years, so I'm quite experienced. But most of my career actually has been in administration. So I was just telling a new friend over here that I call myself an institutional systems therapist. So a lot of institutions that we are in really do need some therapy. So that's what I try to do. And then the other thing they call me, because of my emergency work, you had to carry a radio around. Because whenever you're working with those emergency preparedness guys, you got to have radio. So I had to have a handle. So they call me Psych Lady 1. So just real quick, I have no conflicts of interest. I guess you said that before. And then our objectives are to list 2 healthcare innovations or policy development that supported the evolution of behavioral health integration, to state how behavioral health integration improves the care of patients with chronic pain, and to identify 3 behavioral health interventions that assist patients to manage chronic pain. And you got some of those already done, from your other talks, so thank you for that. So nurses in the audience, we have, how many of you are family NPs or family NP students? Okay. And how many are you psych? Okay, a little less. And then other. Okay. I know there's a social worker here. Anybody else? Public health? Okay. All right. So I'll be talking a little bit about my view of family medicine and my love for family medicine, actually. I've grown to really love you guys. But I want to talk about stigma for a moment. So this is the, head off the body kind of thing. But what we find throughout history is the stigmatization of individuals with behavioral issues or with mental health issues. We equate their mental illness with evil. Insanity was imposed outside of the man as divine punishment for being evil. The religious folks viewed mental illness as the expression of sin. And so we cast out devils. The witch trials, we torture and kill people. We lock them up in separate facilities like the state hospital systems. And even there were special places during the Second World War where they had specific camps for the mentally ill. And along with the stigma of the people we care for is the stigma for us. And so I'm reminded of that when people say, oh, you're just a psych nurse. But what I found over the years is there's even more stigma, I think, with the individuals who suffer with substance use disorder. So I feel actually blessed to be stigmatized as a mental health nurse or someone who's taking care of the mentally ill, wherein those who take care of individuals with substance use disorder truly are stigmatized often themselves as well. But what does stigma do? It has people avoid care. So how many of you think everybody tells the truth when you ask them, how many drinks do you have this week, in a week? All right, you think you're getting the actual answer? Or how many, opiates did you take this week? So they're undertreated, ostracized and feared, and the brunt of jokes. They're denied employment, they have increased poverty, and they lose social supports, which are so necessary for whole health, both physical and mental health. And we lose their contribution to our world. So why I start with stigma is because I think that behavioral health integration actually addresses stigma. It may be the only way that we're going to overcome what has occurred in these siloed systems of care by placing behavioral health in any area, and then we'll talk about that, any area that provides health care. So it improves access, it improves the competence and comfort of the primary physical health care. So for those of you, how many of you work in integrated settings? I should have asked that. Okay. Okay. All right, very good. So have you found that it improves your competence by having the behavioral health person there? Or are you the behavioral health person?
I'm the behavioral health guy working in primary care.
All right, and are you making them more competent?
You're making me more competent.
And it goes both ways. Good point. So it improves the competence and comfort of primary physical health care providers, and it makes behavioral health a part of all health care, and it normalizes the delivery of mental health care and substance abuse care, for that matter. It improves the attitudes of the providers related to patients with behavioral health disorders, and it improves the possibilities of treatment, decreases suffering, and improves the quality of life for individuals with mental health and substance use disorders. So one of the things we've done over many years is focus on the individuals with more chronic and serious mental illness. And in terms of funding throughout the country, a lot of our funding is focused on the chronically and persistently mentally ill. So for those of us who work in behavioral health, that's always been a big focus. What I think the integration movement has done has been to look at prevention, to finally look at prevention, to look at early intervention, and to look at the suffering of individuals who are treated in healthcare every day. Because we have not attended to that suffering, I don't think, adequately. And we have not addressed or identified depression and anxiety and the other kinds of things that, frankly, are a huge burden on individuals and our society. And there's a lot of information right now being focused on in terms of workplace burdens related to depression, anxiety, and that actually the main reason for sick time at most places of employment is related to mental illness or to psychiatric symptoms. So it provides prevention and cares for individuals earlier in the process. So this is one of the objectives. Pay attention. So how did this whole health thing happen? I think that over the last few years, we've really had a lot of focus on patient-centered medical homes. And so most of you are working in patient-centered medical homes, I would think. And the NCQA, that gives you sort of a certification. Is it certification that the NCQA gives for primary care? Is that right? So they give you different levels of certification. And part of that certification has to do with how much whole health you apply to your patient-centered care. And one of those, at least to start with, back in, it's really 20 years ago or so, they started to look at depression and depression screening. And are we doing any screening for behavioral health illness as part of our primary care? And then over the last few years, some of the insurances, CMS, and other kinds of quality-focused care providers or payers want to see some sort of depression screening in primary care in order to reimburse at different rates or to give you that quality layer of payment. And so that's been another element that has helped us to move to whole health. Chronic disease management is another piece. Again, if you're doing chronic disease management, the comorbidity of mental illness with many of the major disease entities, cardiac disease, diabetes is usually some of the ones we talk about, are much better handled if you also handle the behavioral health component of the illness. And then EMRs. Everybody have experience now with EMRs? Okay, so how many of you have EMRs that actually share EMRs with behavioral health? You do. And you guys? Okay. How many are on Epic? I'm just curious, because we're on Epic. So enterprise-wide, EMRs are a huge underpinning for us to be able to integrate. So when we begin to be able to see what the behavioral health provider writes, we begin to be able to understand the person in a more holistic way and in a more whole health focused way. And then parity. So along with the downturn of the economy came a wonderful event, a political event, and that is that we started to look at the responsibility of insurers and employers who insure people, that they must have an equal way in which they look at behavioral health to physical health. And so we actually have a colleague who's working on how to make that happen. So it's been a long time since this act was passed, and we've done a lot of work on what does that really mean to have behavioral health and physical health have the same kinds of coverage for services for individuals. I think we're getting there. There are a lot of loopholes in the way that the parity, it wasn't really a panacea. It still's got a lot of loopholes, and people don't have coverage, or they don't have adequate coverage. But it took away a lot of the barriers to being able to care for people more effectively in the treatment of their mental illness. We have copays, for example, that used to be twice the copays for behavioral health. Now they're the same as the medical plans. So now we have telehealth. So how many of you do primary care on telehealth? Anybody do that yet? We're doing that. So when we did telehealth for primary care, they came to behavioral health and said, we can't do telehealth for primary care unless you do something with mental health care. So we got our act together and we created a tele-psych care now so that our own insurer could adhere to the parity law. So that's going to happen. I think we're going to have, as we have innovations in the way in which we care for patients in primary care, we're going to have to mirror that in psych. And then the essential services. So the ACA really put the behavioral health services in front of the regulators, and we actually have coverage for things. So I don't know if you're allowed to say this, but I didn't go to Walmart for years. The reason I didn't go to Walmart for years is because they had no coverage for mental health issues for their employees. Now, I know they do now, but for many years they did not. You couldn't even convert a medical coverage for a psychiatric coverage. And so I told anybody that would listen to boycott Walmart for those reasons. Okay, so prevention and wellness and whole health kinds of focuses are another reason why we're moving to whole health. The whole idea of holistic care, which is not new to many of us. It just feels like recycled, but it's gotten a lot more traction these days. And then I actually mentioned before, pay for performance or outcomes. If you have individuals with comorbidities, and the comorbidities are substance use disorder or psychiatric disorders, you're going to run into, shall we say, less than optimal outcomes or better outcomes when you treat them both. So what I want to do is try to create the ability to do behavioral health wherever any healthcare is delivered. And luckily, they put me as the administrator for a large health system, and I was able to do some of this. So in schools, communities, and now we even have a street medicine program for the last 5-6 years at our network, and we're adding behavioral health interventions in our street medicine. So I don't know if you've ever heard of Lehigh Valley Health Network. That's where I am the administrator. And we have actually been on the front of the Washington Post for our street medicine program. And I think that the individual who runs our street medicine program will probably get one of those CNN Hero Awards. He's like Sister Teresa. So here's a definition. You can read it. Behavioral health is an umbrella term that addresses any behavioral health impacting health and including mental health and substance use conditions. Okay. Behavioral health integration. And it's taken us a while to try to define some of these. And these are these definitions, and a lot of the lexicon for integration is on the AHRQ site on your resources. So it's care resulting from a practice team of primary care and behavioral health clinicians working together with patients and families using systematic, cost-effective approach to provide patient-centered care for a defined population. This care may address mental health, substance use conditions, health behaviors, including their contribution to the chronic medical illnesses, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. So a lot of times it's those individuals who are less than optimally following their physical recommendations that are referred in these situations. So, yeah, so how many of you get, those of you in psych, how many of you get pressure about not having enough access or quick enough access? Right. So it seems as though I'm always saying I'm sorry, you know. So what I wanted to do was to begin to have some access for my primary care cohorts. So the administrator for primary care at Lehigh Valley Health Network came to me and said, you know, some of my practices want to get into psych and they can't get into psych. And I said, well, you know, maybe you should just buy your own, you know, have your own behavioral health person in the program. So they actually, ooh, what happened here? They actually said, okay, we'll pay for it. So that's why I like family medicine. They were actually willing to pay for it. They were putting their money where their mouth was. They wanted behavioral health access for their patients. And so they said, give us one. Give us one of those behavioral health persons. So we hired a behavioral health person for one of the practices, and we piloted it. And so it worked out really well. Okay, most of the time we were picking a therapist to put in the program. We hadn't put nurses yet, but in the beginning we were putting, and even now, a lot of times we're putting LCSW. So, or I don't know what they call it in this state, like a licensed professional counselor? What do they call them? LPC? Okay. That's what they call them in Pennsylvania, too. So we'd place them in the program, and it was a co-location, but they were actually employed by the practice. So it wasn't as though they were sitting in that program and doing their own business, and you've heard of some places that did that. OBGYN did a lot of that. they'd have a psychologist or somebody in the program to manage the postpartum depressions and those sorts of things. But these were employed by the practice, but supervised by psychiatry. So we helped them hire the person, because a couple of them had actually tried to do this without psychiatry. And what happened was they hired a person who couldn't bill. I call them masters in human kindness. But they weren't licensed and they couldn't bill and offset some of their cost. Now, the reality is, it is an investment. It is an investment that needs to occur, because some of the things, as you have talked about, are not billable necessarily. Some of the kinds of interventions that truly are helpful to patients are not necessarily billable, and I say yet, because I think that there's more to come. So we started then to help them hire the right kind of people, and also people that we felt were more competent than others, and just in case, because we had a tendency to know the community and what therapists were more well thought of than others. And so it worked well, more or less. It was a lot of by the seat of our pants, if you will. We were trying things out, which is probably still true today to some extent, but we are more organized and structured. So it evolved according to the site. It depended on whether the family medicine person was actually interested in having somebody there or using the person, or how they wanted to use the person. Sometimes they wanted to use the person just as a case manager, like social worker or something, and get them to refer the patient out. Sometimes they wanted to just, give the patient to them and not hear about that part and go about their normal family medicine practice. But as we evolved things, we tried to intervene with the provider, with the family medicine practice, and prepare them more effectively for having an integrated provider. So why would you want an integrated provider? We have a whole set of readiness criteria to try to, shall we say, from the onset, understand what the goals of doing this were. So let me just talk a minute about barriers. And there are some as we evolve as well. There are barriers related to stigma. So they wouldn't necessarily, they thought too, if they had a behavioral health provider, would their practice attract more behavioral health patients or more individuals with mental illness? And so they worried that that might be the case, like build it and they will come. And the reason we were doing this was because we really weren't very comfortable with them in the first place. So there's the stigma. And then chairman. So the chairman in our network for family medicine and the chairman for psychiatry hated each other. So I know you find that shocking, two narcissists hating each other. but they were pretty difficult to try to get together. So what we really needed to do, myself and the administrator for family medicine, and some other very dedicated psychiatrists and primary care providers, is to do what I call covert ops. So if you stay under the radar of the chairman, who are, fighting, and proceed with what you needed to do to try to start to sell this to primary care providers, such that we get enough impetus to get to a point where it becomes the norm or something that is desirable to pay for within the family medicine practices. That was what we did. So money was one of the things. Now, my boss, loving the other chair, did not want to spend a dime on it. And again, family medicine was our hero, and they wanted to pay for it. They felt it was important enough to pay for the individual who would be integrated into their practice. And they were even willing to pay for NPs, and they were willing to pay for psychiatrist time even. Now, we didn't have a lot of psychiatrist time because we know there's a little bit of a shortage there. And there are for NPs as well. So money was part of the issue. We also figured out how to bill whatever we could bill so that we could offset the cost of integrating that behavioral health provider into that area. And so behavioral health billing can be a little bit unique. The payers sometimes are carved out, and that can be difficult to get credentialing for, or insurance privileging. So that was a logistical issue. The other thing is we had no dedicated supervision from psychiatry for these individuals. And so one of our psychiatrists actually donated her time to do the supervision of the individuals. And then one of our directors, who was an LCSW, also donated her time. And I donated my time, shall we say, to be able to do what we thought was the right thing to do. And so we did our covert ops, and we did it during our workday, but then our work days were longer, if you will. So competency was the next thing. So it's a barrier really, is that we ain't never done that before, So we had to figure out, how are we going to do this in the practices? Plus, we had nobody really with a real job of supervising these individuals or structuring the program, or really, having the time to oversee and think about what are the competencies that these individuals need in this situation. And so a lot of work has been done by SAMHSA in terms of integration. So CIHS will be in your resources as a way in which you can get a ton of information about integration with behavioral health in primary care settings. But we used what we could. Free webinars. We used the SAMHSA website, and we asked people to go to the CFHA, which is Collaborative Family Healthcare Alliance. So that's in your resources as well. And they're a group primarily of psychologists, because they seem to organize well, those psychologists. I think their organization has probably a ridiculous, like almost everybody who is a psychologist belongs to APA. So they did put together quite a bit of information on integration. What I hope to see, and then social workers kind of followed suit, and on the SAMHSA site there's competencies for social workers. But what I really would like to see is more and more nurses taking roles in integration, because I think we're perfect for this work. So true integration actually takes work, and a lot of the barriers have to do with our own comfort level or our relationships with the individuals we're working with. So we have to pay attention to letting go of some of the control we might feel we need when we're practicing, and how do we actually do collaboration. So co-location is not that hard, but true integration is quite hard. And so we've struggled with a number of things in integration, like even turnover. So you think you got a really good understanding of integration, and then what happens in practices, and many of you probably have experienced it, is your clinical staff rotate, and it's a new set of clinical staff. You're working it out really well with that nurse that was there before, and then she moved to another practice. Or your MAs or medical assistants actually understood what you were doing, and they move out, and someone else. Or providers move from practice to practice, especially in large systems. So we have 7 hospitals in our system, and we have over 800 physicians, both primary and specialty. We have over 600 nurse practitioners and PAs in our system in 160 practice sites in the region of Pennsylvania, sort of northeast middle is where we are. And so this is a picture of sort of how we started. I have to, again, kudos to family medicine. They realized they were the de facto behavioral health care for many of their patients. And so what they did was start to put behavioral health as part of their residency requirements. And so I'm not sure what nurses are doing with the family medicine, but you've got some behavioral health focus in your clinical as well. and in your didactic? Not enough? Well, the residencies they have a pretty hefty focus on that. So I will give them kudos they were sort of the beginners at our network. Then we had AIDS Activity Office and cancer. Those are models where we look at more holistic health and maybe even some alternative stuff. And then we just started adding folks and integrating in the other practices. So currently, we have 37 practices, or 37 behavioral health specialists who operate in about 58 of our practices. So if we think about 160, we still have more work to do, but we're getting there. We have about a third of it integrated. And we have added not clinical nurse specialists, CRNPs, that's what we call them, but APRNs, psych, mental health APRNs to the mix as well. So we have it in specialty care and in primary care. And pretty much we're adding about 3 or 4 practices each year with integrating further. The other thing we did was instead of us doing this as a side job, we actually hired a director for behavioral health integration. And I'm starting to see organizations do that, hire someone who actually can structure and work the system, and to actually help our individuals who are doing the work understand better how they could more effectively do the work. So why should behavioral health be part of primary care and healthcare? Well, so it saves lives. It saves suffering, but I'll just talk a moment about suicide. And so you had brought up the statistic of 28 to 48% of individuals with chronic pain have suicidal ideation. So part of what we've done in our network and part of the role of our behavioral health specialists, and pretty soon our role of all our family medicine folks, is every touch, every time suicide screening. So I don't know how many of your organizations or your practices are doing do you feel safe at home? Right? Do you feel safe at home? It's pretty standard that's an expectation that we ask people about abuse. But I would say, do you feel safe at home from yourself is probably one of the questions we need to ask as well. So we are working towards every touch, every time doing a suicide screen and using an evidence-based suicide screen with the zero suicide. Are you all familiar with zero suicide? All right, go ahead and Google it while I'm talking. But Google it after I talk. But zero suicide is a national initiative that begins to use evidence-based suicide screening, suicide management, and identification of individuals who have suicidal ideation. So a few years back when I started to do some focused suicide work, the Parkland Hospital, where one of our colleagues, Celeste Johnson, worked, had done a study in the emergency room. So the emergency room did ask people who did not present for behavioral health issues, so that group was excluded. The other patients that came into the ED were asked or surveyed about whether or not they had suicidal ideation, and something like 11% of them did. So the individuals were presenting for medical reasons, but were actually suicidal. And so we also know that people that die by suicide have visited their primary care provider. I think it's somewhere in the neighborhood of about 60% of them have visited their primary care provider in the last 4 weeks. So the other thing is if you're a 70-year-old man, it's even higher, the incidence of dying by suicide, having visited your primary care provider. So to do every touch, every time, starts to make sense. Oh, let me just say, it matters to that one. So there's something that helps me think about it and illustrate it to people, because you do get some pushback when you say, I want you to talk about suicide every time you talk to a patient, and you should be with your chronic pain patients. is the story about a young boy walking on the beach. And a bunch of starfish have come up. I'm a beach person, so every blue moon, a bunch of starfish come up on the beach, and they're usually in mass. Anyway, this young boy was walking on the beach, and an old man was watching him, and the boy was reaching down and throwing the starfish back in the ocean, kept doing it. Anybody heard this story? My dad told this story. He's a minister. And so the old man goes up to the little boy and says, you know, you're not going to save all those starfish. And he bent down and he threw another starfish in the ocean. He said, well, it mattered to that one. So that's the way I try to get across to folks why it matters, the suffering and even the life. So the legacy of separate and parallel systems, this is sort of basic, and excuse me if you know this, but there's medical care and there's mental health care. And it forced a choice between them, you know. And so as we talked about today, there's really a need for a blend of behavioral health and medical care in the care of people with chronic pain. But it's two kinds of problems, two kinds of clinicians, two kinds of clinics, two kinds of treatments, and two kinds of insurances. And so the managed care movement in the 90s, and one of my nurses at that time said it's mangled care. It was for psych. It made it so that we actually carved the brain from the body and created different insurances because we knew those individuals with behavioral health needs were going to, you know, cost us a ton. You know, they were going to cost us a ton, so we carved it out. And I think it really was damaging to our healthcare system. So I'm glad to see us put it back together and start to, actually even the insurers are starting to put back the benefits as unified. They may have some processing that they do, but at least it's not a carved out company, a totally different kind of insurance. So maybe Magellan will go out of business at some point. Because although, actually it's interesting, Magellan is actually going to go into the physical healthcare business. So Magellan, for those of you who don't know, is one of the bigger providers of mental health insurance or insurance care management for mental health disorders and substance use. But they're now talking about getting into the medical business, so maybe we can start to blend some of these, because payment matters. So as we know, primary care is the de facto mental health system in this country, and we have experienced the lack of treatment as part of the problem in those systems. And it's not to demean primary care, but often they're undertreated or not treated to full remission in those locations. And as we learn and as we partner in these situations, we'll have better outcomes. So the other thing is, if you tell a patient to go to seek care, you know, again, the likelihood of the individual going to seek care for behavioral health issues, what's the percentage? Nobody actually knows, but it's around what we think it is about 50% at best actually go to care. So there's a high prevalence of behavioral health problems. There's a high burden of behavioral health needs. Sorry about that. High cost of unmet behavioral health needs, and lower cost when we actually meet the behavioral health needs of patients and better outcomes. So there's a high prevalence, of course, of behavioral health problems, particularly with chronic illness. You had some of those statistics as well. Lower costs when behavioral health needs are met, and better health outcomes overall, even for patient satisfaction, when we do. So the leading determinants of overall health. So I like this. It's a little old, but it's behavioral health is probably one of the leading determinants of overall health. And the president of APNA, actually last year, her theme was whole health begins with mental health. So if we think about an individual with any kind of illness, how well equipped are you to care for your own health and wellness if you suffer with mental illness. And so you've probably seen that complicate your pain treatment and your other care treatments when you have a comorbidity, if you know about it. And usually you're going to know your patients well enough to have some sense that that's an issue for them. Then the question becomes, will they do what you ask in terms of seeking treatment? So unmet behavioral health needs are, I have what? My clock went off. Anyway, unmet behavioral health needs, 67% of individuals with behavioral health disorder do not get treatment, 30 to 50% of referrals, and that varies. Don't make that first appointment, as we said, and 2/3 of primary care physicians reported not being able to access care for their patients. And depression goes undetected in 50% of the primary care. So we instituted depression screening in our network about 3 years ago for all primary care patients, and then a year after that for all pediatric patients. And so what do you think the compliance is with the depression screening? It's not where we want it to be. It's about 67%. So we can do better. So now what we're doing actually is working on a depression clinical pathway so that if we have interventions that can be evidence-based after we screen people, I think folks will feel better, armed with some additional information. Okay, and so top 5 conditions driving overall healthcare costs: depression, obesity, arthritis, back pain, there you go, anxiety. And what I don't think is captured here, and it may be captured now that we're paying attention, is substance use disorder. But again, we run into the issue of people not necessarily being totally honest with us about what they're doing. And then I guess we could drug screen everybody and maybe we'd know, but feels a little invasive. So again, these are the high cost of unmet behavioral health needs. And these will be, these are available to people, the slides? We can make them, yeah. And so just a brief thing before we get to pain, and that is, these are the standard models for those of you who may not be familiar, but these are coordinated care, co-located care, and then integrated care. And so integrated is really the goal, but these are sort of on the way towards the goal. There's a lot of coordination of care occurring right now with population health and with doing different kinds of interventions for patients who are high risk. So we have one of our behavioral health specialist models is a community care team. Has anybody heard of community care teams? Okay, so community care teams are really the nurse. This part I like. The nurse is a hub. She's the care manager. She or he has a behavioral health specialist who work with them. They have a social worker for social determinants of health, and they have a pharmacist who works with them. And what they do is look at high-risk patients and coordinate the care of those individuals to try to improve outcomes and to reduce costs. So that's another way we integrate into the coordination and high coordination, tight coordination of care for patients. Okay. And I'm thinking, I forget who was one of the original ones. It might have been Connecticut, I don't know. And then North Carolina was the other one. Anyway, we have now somewhere in the neighborhood of 24 of those teams working with our patients in our network. And so that's another way we try to integrate care in our network. And nurses, I think, are perfect for this work. And I don't think we're doing enough of it. But I will tell you that the reason, one of the key pivot points for the programs or practices that have been successful with integrating behavioral care is the buy-in of the nurse staff in a practice. So when they buy in, things move we are the coordinators of care. We always have been the coordinators of care. We've always done everything that needed to be done for a patient, including empty the trash if we had to. So I think that what happens then is they're the glue to try to, well, that patient needs some help. I know they do. Even if the provider doesn't necessarily see that, they then can do a handoff to our behavioral health folks. Or the nurse can be the recipient of the handoff. I would like to see that happen more often with advanced practice psychiatric mental health nurses being those recipients. You know, nurses have high touch, whole person, person-centered, and compassionate care. And we are pretty darn good at suspending judgment, I think, when we see suffering. We always need to get better. That's why we're even talking about stigma. And so some of the competencies that I think nurses have that blend particularly well with integration are advocacy, prevention, recovery-based. So really what you're trying to do in chronic pain management on the behavioral health side, or even in total, is to improve the quality of life and the function of individuals in your care. And to use evidence-based practice. We're getting better at that. And we're good at care management or case management. I think people like the term care management better. Peer counseling is another thing that we're using, and I think could be used more effectively in chronic pain management, so that if we actually, those who have been successful in the management of their chronic pain could be deployed to help with other individuals. I think the whole peer counseling model is useful not just in psych, not just in AA or sponsorship, but I think in all disease and complex disease situations. I think if we used people's experience, it would improve our care. And then we have competence to cross the divide, if you will, between mental health and substance abuse and medical care. We're also pretty good behavior coaches, health behavior coaches. I think the way in which nurses use their ability to teach people and to motivate people. We were talking about motivational interviewing earlier, and we have done it all the time. So like, what can you do if you can't go to the gym? What could you do to move more effectively and to help your pain management? And then measurement. So talk a little bit about chronic pain, since that's why we're here. Your goals matter. And it's not the goal about pain. It's not about the reduction of pain. It's about what is your goal for recovery. And so in the mental health world or the psych mental health world, we're very focused on what do you want your life to be? And how do we assist you in getting to a better life for yourself, regardless of what your pain scale number is. So the goals matter. Don't set goals about the pain so much as setting goals about what you want to do in your life, what matters to you. So we've talked about some evidence-based treatment approaches, mindfulness, CBT, other treatment components. We do have an Institute for Mindfulness in our network, so there's availability of the full program for patients and for staff. So we talked a little bit about burnout with this particular group of folks. How do you retain your mindfulness in the session with the individual you're caring for? So an awareness of the present, observe pain with less reactivity, ways to find pain less aversive, increase your symptom tolerance, and again, non-judgmental stance about your own pain even. And for those of us who are caring for them, about the individual. And then how to be kind to yourself and have less anticipatory pain and help foster cognitive change. So these are, how many of you practice mindfulness? All right, good. So I think we all got to practice to get better at it. And then CBT was brought up before. So thoughts, emotions, added physical sensation, because in pain management, that's a piece of it too. So for those of you who are not psych nurses, I have a little bit more for that. How is that pain interpreted? Not the pain itself, but our view and interpretation of that pain in the context that determines our suffering. So, you know, during certain kinds of events, we don't even pay attention to pain, but when we're alone and sad and feeling bad for ourselves, it seems like it gets worse. So using homework and using CBT kinds of tools after a disturbing event or the pain that you experience, we have an emotional and behavioral response, and we assume it's due to the event when it isn't. It's related to other things. It may even be neurochemicals. We react to our interpretation then, not the event. And so, you know, if I have this kind of pain, I'm not going to be able to work. If I have this kind of pain, I'm not going to be able to take care of my children. I'm not going to be able to have my grandchildren. Other kinds of things that enter into how you analyze it. So you can't believe everything you think, even about pain. So really, cognitive behavioral therapy is trying to intervene about those thoughts, feelings, and behaviors, and break some of the cycles and distortions. So inherent in how people think is a faulty way of processing, and I've been known to do that too. And so when we make systematic logical errors, we create for ourselves actually a situation that is self-damaging or self-perpetuating. So different thinking styles. All done? Ooh, okay. All right, so we're almost done. Catastrophizing is the other piece that we talked about, and you'll have these in the slides, and counteracting your automatic negative thoughts. So I'm going to go into my question area a little bit. We've got to go over there. Okay. So the other thing is exercise, massage, and these other ways in which we intervene. Sleep and stress management. And I just wanted to go through this. I just want you to see, in our network, what we've done is we've created a website that has all kinds of information. And you'll get these so that for education and for algorithms. So Dr. Kara talked about the first visit, what we should do in the first visit, and what kind of checklists we have. And we make our providers actually use the website. And then the other thing, here are a number of websites for you. Is what we'll try to do is monitor how our providers are using opiates and how our patients are using opiates in order to more effectively give them feedback on what they're doing that is not effective for their patients. So, we're done? Okay. I have one case example. I'm just going to do it. Well, that's all right. The case example actually is a paraplegic that one of our therapists worked with for 2.5 years. He had extreme pain and was abusing alcohol. He had become a paraplegic when he was 19. What she did was use all the bag of tricks. And that's the thing. We've got to build a bigger bag of tricks in order to care for patients who have chronic pain. And using that, she was able to have him improve his function, his life, his work, even his relationships. And he eventually actually became much more physically active and does skydiving now. So as a goal of his was to actually do skydiving. And so she worked for 2.5 years with him on a number of different issues that were impacting his chronic pain, improved his life, and he's doing amazingly at this point. So, thank you.